my name is Shahina Dawood and I'm a consultant medical oncologist coming to you all the way from the United Arab Emirates, and I'm here in Penang, Malaysia at the Asia Pacific Breast Cancer Summit 2026 with Hope Rugo, a world-renowned expert in breast cancer. Hope, would you like to introduce yourself?
Yes, it's such a pleasure to be here. Thanks for talking with me today. I'm Hope Rugo. I'm a breast medical oncologist, the division chief for breast medical oncology at the City of Hope Comprehensive Cancer Center, where I also lead the Women's Cancers Program.
Thank you, Hope, for being with us today. As you know, the last decade, we've seen an explosion of data coming in terms of the adjuvant therapy of patients with ER-positive, HER2-negative early-stage breast cancer. What, in your thoughts, are the biggest unmet needs in these patients?
You know, I think that as clinicians, what we see with patients is that we treat them with our absolute best therapy. We, look at all our genetic, markers, and we look at gene expression signatures, and we do all these randomized trials, and we see them back again at 8, 10 years, sometimes 5, 3 years with metastatic disease. And I think that's the most frustrating part about treating hormone receptor positive disease. And it's funny because, you think about triple negative and HER2 positive disease being such aggressive cancers, but we probably cure more patients with advanced, more locally advanced disease in those subtypes than we do with ER positive disease. I always think of it like locusts. It kind of sits around and waits and is dormant, which is something we don't understand well, and something triggers it to come back. And, I think that this is a huge area of unmet need where we're making inroads, and it's very exciting. I think San Antonio, I thought, wow, we already are curing more women, but we're really making a big advance here, and we'll be curing more women of early stage breast cancer, which is exciting, going from hormone therapy to adding targeted agents to new hormone therapies.
Absolutely. Last year, you published a real-world data set that looked at risk stratification of patients with ER-positive, HER2-negative early-stage breast cancer, looking at those patients who had not received adjuvant CDK4/6 inhibitors. And you had some very interesting insights into that data set, including the fact that you had a subgroup of ER-positive patients that had a prognostic outcome that was very similar to triple-negative breast cancer patients. Could you walk us through that risk stratification?
I think the risk stratification in the real world setting is complex, but we do know that there are specific factors which play a role in risk. And it's hard because, it's not just young age. There's something addition to young age, but we do know that very young women have a higher risk. And there actually was some data from a trial from ATAC that looked at women, and from Soft and Text, because ATAC looked at postmenopausal women, but you could be postmenopausal with ovarian, taking out your ovaries. And I was really struck by the fact that in Soft and Text, the luminal A, even if you had luminal A biology, if you were very young, you had a higher risk of recurrence with optimal endocrine therapy. And then I think we know that there are more risk factors now. So, in addition to the real world stratification, we saw in the 15-year update of Soft and Text that having high grade histology was an independent risk factor for recurrence. So high grade, lower ER, younger age, and then having, I think a number of different factors that also include just burden of disease. But what I think was striking about that real-world analysis is that even in patients who we traditionally had thought, you just give endocrine therapy and it's way too much to give CDK4/6 inhibitors, there is a subset of patients who have a much higher risk of recurrence. And
Absolutely.
There's nothing more difficult in our clinics. I mean, it's one thing when you have a patient with 20 positive nodes, but when you have these patients who are node negative with smaller tumors who develop metastatic disease, it's very difficult. And I will say, one of the areas that we really have to overcome is people not getting endocrine therapy. And I think, the issues of toxicity of endocrine therapy and patients not being able to be adherent, and, because they just can't tolerate it. We have to be better at helping patients through that. But also, it was interesting looking at responder in the node positive patients, that so few patients, 20% received ovarian function suppression who were premenopausal. This is a big area of unmet need, and
Absolutely.
It combines with the next steps.
No, absolutely. I always say that instead of moving on to very expensive therapy that you add on, first optimize what is the basics, which is ovarian function suppression in our premenopausal women, and of course using that aromatase inhibitor early on rather than later on. So now we have 4 randomized clinical trials looking at CDK4/6 inhibitors in that adjuvant setting, trying to translate the overall survival advantage that we saw in the metastatic setting. Before we go into the 2 positive trials, we have 2 negative trials. Why were these trials negative?
I think this is kind of water under the bridge now, since we know we're not going to be using palbociclib in the early stage setting. But it's an interesting question. I don't know. I mean, because I think palbociclib, certainly is the best tolerated of the CDK4/6 inhibitors, but there's questions about the metastatic data. In our real-world data sets in the metastatic setting, the benefits of palbociclib appeared very similar to ribo and abema, but in the trial populations we saw differences. And we know that we've seen this now with the ADCs in the metastatic setting, lots of things that the populations are just different, and we don't know. But a lot of work was done. I think that PALLAS is really the only one you can interpret because it's larger, right?
Of course.
And the other trial was just too small. But even looking at subsets, which reduce your power, it was impossible to see a subset that benefited. So I think what has been shown with PALLAS is that if you got a CDK4/6 inhibitor and you develop metastatic disease, let's say you were in the control arm in that group, so they were randomized, palbo versus no palbo. If you were in the control arm or the CDK4/6 inhibitor arm and you developed metastatic disease, that you didn't do as well if you didn't get a CDK4/6 inhibitor. So it's really important for us to take that information to how we're treating patients now and treat them appropriately in the metastatic setting. That was data presented at San Antonio. So the trial has given us a lot of interesting information, but why it didn't work, we don't know. Now, I will also say that that was the first trial, and there was a lot of concern about regulatory groups as well as the groups who were organizing the trial about managing toxicity. And the other 2 trials allowed a lot of leeway, but in PALLAS, you had to dose reduce if you had neutropenia, things we don't do in clinical practice as much. Could that have played a role? Nobody could really determine.
But I think as for now, the clinic, we should not be exchanging these CDK4/6 inhibitors. So for example, if ribo and abema were not available, we should not be using palbo in the early stage setting.
It's so hard to say. We didn't see any benefit in a phase 3 trial. And I think you can generally go back and forth between ribo and abema if you have toxicity. With one, you go to the other and it generally is okay. I've never had a situation where I had unmanageable toxicity from both. Okay. So I have found, that people have liver enzyme elevations with ribo, I switch to abema. If they have problems with diarrhea, I switch to ribo. So that seems to work okay. In the metastatic setting, if you have severe liver dysfunction, that's one situation where I have switched to palbo, and that works well because I feel comfortable with palbo in the metastatic setting.
Okay, so let's now deep dive into NATALEE. Can you walk us through the trial schema and the results of NATALEE, please?
So NATALEE was different from the monarchE trial in that it gave 3 years of ribociclib versus 2. You have to be different. It included a moderate risk population of patients as opposed to the high risk population that were included in monarchE. And indeed, that population does have a later recurrence risk because the trial, NATALEE actually amplified the high-risk patients after monarchE reported their data, adding 1,000 patients. So those patients who have higher risk have a slightly shorter follow-up, but it took a little bit longer to find the benefit in the node-negative population. So they included patients who had a high-risk disease that was node-negative, but not stage 1. So these patients were T2, node-negative, and had high-risk features. So they had to have high-grade histology, a high risk by a gene expression test, and those things helped you, assess that they would be higher risk of recurrence. And in fact, that's what our real-world analysis we talked about earlier also showed, and so did soft and text. So then there was also in monarchE, you had to have features if you had 1 to 3 positive nodes. But if you had a positive node, NATALEE, you were eligible. So that there was a span of node positive disease in the lower risk node positive and higher risk node positive. and then patients got 3 years of ribo. The other thing they did, which was very clever, I thought, was to give a lower dose of ribo, because something like 70% of people dose reduce, and I have to say with the data from NATALEE, even more now. It's probably in the 80% group in the metastatic setting, dose reduce from 600 to 400. They just are neutropenic all the time. And with 400, the tolerance is much better. So they used 400 milligrams. And even so, there was 20% or so of patients who didn't finish 3 years. They mostly finished, maybe it's a little bit more, mostly finished 2 years of treatment. And yet still, we were able to see a significant improvement in invasive disease-free and distant disease-free survival, which I think is our most important.
Absolutely.
With the most recent update, we saw a significant improvement where previously the hazard ratios had crossed 1 in the node negative group. Yeah. And to me, that was a very important next step, and just showing that, you need a little bit more time to see that group. And it's actually what we saw was this, carryover effect, where there was an incremental improvement, ever increasing percentage difference until you got out to a certain point in time. And then that difference stayed the same, because in the monarch E population, in the high risk population, those risks are more front loaded. In the node negative or the node positive lower risk population, you're going to see continued risk as you go out. And that's what NATALEE is showing us. There's a trend towards overall survival. The trial wasn't powered specifically to look at overall survival as a primary endpoint, but it is a secondary endpoint. It's a little bit too early. That's certainly a trend, but not yet significant.
So let's circle back to the node negative population, because that's where everyone is wondering whether they really should use adjuvant ribociclib. And like you've rightly pointed out, a lot of these patients are high risk and they do tend to recur. But when we look at the ASCO recommendations, they say give it to everyone that fits NATALEE, but there may be a subgroup within that group that may not require adjuvant ribociclib. How do you tease that out in the clinic when a patient comes to you and says, look, I've got node negative disease, my tumor is small, why do I need something like adjuvant ribociclib?
Well, in truth, we don't have data in the T1C, T1A, T1B, and we should not be giving ribo to that group of patients. I will say, if you have a 2 centimeter tumor, it's still T1C and LVI and high grade histology and, a Ki-67 of 90%. Probably that tumor isn't that endocrine responsive, and it doesn't really matter to you. Those tumors need chemotherapy. But if there's just the sort of high risk features in that group, I think that what I say to patients is, look, the benefit may be a little bit smaller for you, but if cost is not an issue, it's worth it to try, because we don't yet know how to individualize, and we also don't know how to use some of the newer biomarkers. Absolutely. Like, for example, some patients are like, well, if my ctDNA is negative, then I won't use the CDK4/6 inhibitor, but the trouble is that then you could acquire the ctDNA, and we don't know that you can rescue somebody back. But that is going to be an important question, I think. But I also tell patients that some patients didn't finish the 3 years, so if they're really tired in 2 years, we'll just stop because they have lower risk disease. I think, it's hard. If I see patients whose tumors are greater than 2 centimeters, node negative, younger, who I wouldn't give it to, 75-year-old. I mean, who might not tolerate the treatment, lots of comorbidities, even in a slightly younger patient. If there's a lot of competing causes for mortality, probably you don't want to be, trying to make them sicker. And also, I think it's important, if somebody couldn't tolerate ribo for an older patient, if you were going to give abema for a lower risk tumor, even though it wasn't part of monarch E, we do switch when people have tolerance issues. You have to be very careful of diarrhea in older patients, because you don't want them to fall, get dehydrated. So I think you do have to individualize based on that. If you have somebody who's a really poor, pill taker, things like that, doesn't show up to clinic, these are issues where, you have to take the first do no harm approach.
So what if you had a patient who's 45 years old, perimenopausal, 1 lymph node positive, you send it off for oncotype, and the oncotype comes back as 15, for example. First, would you give that patient chemotherapy because the patient is perimenopausal and we have this whole issue regarding our exponder? And second, technically this patient also fits NATALEE because she has 1 lymph node that's positive. Would you give adjuvant ribociclib?
So in that situation, with a lower score, say grade 2 histology, so that she doesn't fit monarch E, I would offer endocrine, ovarian function suppression. She's going to be in menopause soon anyway, and AI, and ribociclib as an approach rather than chemo. I would talk to the patient about it. I don't think chemo solves the problem for those patients is the issue. I think we've seen from NATALEE, looking at that slightly lower risk population, that the recurrence continues out farther than we would expect chemo to be changing outcome. So I tend not to want to give chemotherapy to those patients. And I recently had a patient, that people are so concrete. They're like, you need TC times 4, and the patient didn't want it, so she just didn't do anything, So it took a while to sort of work through that process. I feel really comfortable with that approach, even though the offset trial is ongoing, and we want to try and enroll in that trial to try and help understand the true benefit of both approaches. But I feel like this is a better approach to use a CDK4/6 inhibitor. Now, if you had a higher score, it would, higher a recurrence score or higher, say, mammoprint score, I would be more thinking of using a short course of chemo. But then we're still going to give the CDK4/6 inhibitor, so it's hard,
So that takes me to my next question. There's been a lot of discussion around the fact that should we be replacing chemo with a CDK4/6 inhibitor? And what are your thoughts there?
Well, that's the thing. I think,
patients.
For high-risk patients, we're not ready to do that. And what we saw in patients who had high-risk scores was that, if you looked at AC versus ACT in that old NSABP trial, they looked, we had hoped that if you had a higher recurrence score, you would see that Taxol was really the thing to do. You needed to give paclitaxel or docetaxel in that setting. But it turned out it didn't really matter. People did better if they had high risk disease and they got more chemo. But the problem was that you couldn't differentiate that by the recurrence score.
Okay.
And so the high risk score didn't, it wasn't like you gave AC versus ACT and it was a better approach. So I think that what we've learned is that, these are patients where chemotherapy can benefit, right? But we still have a recurrence risk. That's unacceptable for those patients. So I think in a high-risk population, we're not looking at replacing chemo, we're looking at improving outcome by adding on to what we already do, which isn't adequate, right? We cure a lot of women, but we don't cure too many. We look at those curves. You look at SOCT and TAX, there's still recurrences out to 15
Absolutely.
years. So that's not going to be cured by giving chemotherapy. That's the earlier part of recurrence risk. This is where we can really change the outcome by changing what we do for endocrine therapy to make it more effective. So for the patients intermediate, lower risk, yes, I think that this is a situation where the chemo benefit, I don't know if you optimize the endocrine therapy, are you really going to get as much benefit from chemo as you want? And it makes it worth it to get chemo, and that's what offset that trial is asking. But for the high-risk patients, I think we really want to add. And it, of course, now comes up, what do we do with oral SERDs? So, someday maybe we'll be using oral SERDs, either, with a CDK4/6 inhibitor in sequence, we don't know yet.
So whenever I have a patient that comes to me in the clinic and I want to start them on a CDK4/6 inhibitor, they've gone through their journey of their surgery, their chemo, their radiation, and I put them on optimized endocrine therapy. And I want to start a CDK4/6, and they tell me, but why should we take this? It's like chemotherapy. And that's what they read on the internet. That's the education that they're getting out there on ChatGPT. So how do you educate a patient and tell them this is not chemotherapy and that this is important for you?
I use graphics a lot, and show people curves and the benefits and the distant recurrence because, overall survival difference, I remember when they were presenting that data, there were people around me saying, well, it's only 1.8% in monarchy. I'm like, this is immediate, and it's early still, right? It's very early because we have more effective therapies in the metastatic setting, but who wants metastatic disease?
Yeah, exactly.
So I think, it's really saying, distant recurrence isn't curable. You will eventually die of that disease, and we have a significant chance of reducing the risk of distant recurrence. And so graphics, I think, help a lot. And then I think reviewing the toxicity, I'm big on supportive care and managing the toxicity. So I talk about the things that are going to bother them, the fatigue. We can generally manage by dose reduction, sometimes treatment breaks. The hair loss, hair thinning with oral minoxidil. We watch the labs. Generally, people tolerate the treatment reasonably well and they do okay. And so, we talk about the fact that it actually is really worth it to start. Let's see how you do with it.
Yes.
We can manage this. Once you start, we're going to take really careful care of you and manage your symptoms proactively. And that makes a big difference. So I haven't had people say, no, I won't take that therapy. That's going to reduce my distant recurrence risk, you know.
No, unfortunately, I've had patients who are just not wanting to get on additional therapy that might be like chemotherapy because of what they've been through. I think it's just different ethnicities,
but you don't get
different
nausea, you don't get a lot of this. We go through all of this and say, this isn't really chemo. And I do think around the world, there's an impact from cost, you know, so people are thinking,
Exactly.
I got to pay this out of pocket. Is it really worth it? And where am I going to take that money away from? And then I'm not going to feel good, right? So am I going to take away from my kids' education? You know, whatever it is, my housing. So that's a big issue.
No, absolutely. Now you've got two trials. You've got monarchE and you've got NATALEE, and the entry criteria for the two in terms of starting the treatment was different. monarchE, it had to be within 3 months, while NATALEE, you could take up to 12 months from starting your endocrine therapy. So what do you think is the optimal time to start CDK4/6?
I don't see any reason to delay treatment. Again, you know, dormancy, ctDNA, why let it hang around? I had a patient who had, it was such an interesting situation, but she's, you know, premenopausal in her late 40s, so going to be perimenopausal. And she had a 1.8 centimeter, 1.6 centimeter grade 2 tumor and negative nodes, but she's kind of neurotic. And so she went and got her pathology reviewed elsewhere, and she wanted them to recut her nodes. And somebody somewhere found a positive node, which was amazing, right? I mean, a micromet, but a real positive node that had been missed at her center, which is a big center. A little scary for her. And then it set up this real, like, I don't believe anybody, and I've got to do my own work to save my life, right?
Of course.
And she's still, you know, a long time later worried. So she had a recurrence score that was in the low teens, right? So what she did was she had her surgery in July. She just took ovarian function suppression for 6 months while she was trying to decide what to do. And, you know, I saw her as a consulting patient before I went to Southern California. Now she's my patient. But, you know, I said, look, you know, waiting is not a good thing. You just need to decide. And if you can't live with yourself without getting chemo, just get the chemo. So she said, in the end, she decided 6 months later, she would get ctDNA, have her ovaries out, and start letrozole and ribo. So she had her ovaries out, started letrozole and ribo, but she got a ctDNA, which showed a chromosome 5 and 3. Like, really? This is a small tumor, you know, low score and recurrence score. And I said, look, you haven't really started effective therapy yet. Now, the chromosome 5 went away completely. Chromosome 3 is probably this background clonal hematopoiesis called CHIP, and because it's below the reportable limit, very tiny. But after 5 more months, she got TC chemo. So now it's a year after her surgery. Now she decided to get TC. So I tell that story really because I think it's so much better to do things earlier. And there was a little bit of data looking at chemo from a study in Mexico. You know, people don't quote it a lot, but it was kind of, you know, like in triple negative disease in particular, but I think in higher risk disease that the timing made a difference. So I think you want to start when you can start. You do your radiation, you do your chemo radiation, and as soon as you're done, you start the CDK4/6 inhibitor. I usually give it 2 weeks because if you start on the day after the radiation, then you have low counts.
Yeah.
So wait a couple of weeks. But I don't see any reason to wait. And then, you know, the other thing is that what's really bad, it's like starting ovarian function suppression after your chemo. You don't want to wait for the ovaries to come back because then the toxicity is like amplified so much. You might as well start right up front.
So let's shift gears to monarchE in terms of that high-risk population that was enrolled in monarchE. Could you walk us through the study schema of monarchE?
So monarchE included patients who had 4 or more positive nodes, or if they had 1 to 3 positive nodes, they had to have high-grade histology, a Ki67 that you couldn't have a Ki67 alone, high-grade histology, or a tumor that was 5 centimeters or greater. And then there was a separate cohort that could have 1 to 3 positive nodes, not a bigger tumor, not a high-grade histology, but just a Ki67 centrally determined that was 20% or greater, and that was 9% of the population, so it was a small cohort called cohort 2. So, and the reason why they selected, we all worked together, and Stephen Johnson is obviously the main PI of the study, was because of data actually from the Spanish cooperative group that had really looked at their population. And if you looked at those population of 1 to 3 positive nodes and those factors, they had their risk of recurrence was more front-loaded. And so the idea was to try and find results as fast as possible. So that's the group of patients for 2 years. And like NATALEE, there were a fair number of patients who discontinued in the first 3 to 6 months. And even so, they're still an intent to treat, right? You think about it, even with those patients who discontinued, and with NATALEE, the patients who didn't take 3 years, took mainly 2 years, we still saw a benefit with now an improvement in overall survival in monarch-E, which is, I think, very impressive and not unexpected given the improvement in distant disease-free survival.
So a lot of questions have come up about the fact that you have such a high-risk group of patients enrolled in monarch-E. Why did it take so long to show an overall survival benefit, even though it was small? And the curves will definitely continue to separate over time, but why did it take that long?
It didn't take that long. I thought it was the exact right time.
So it was a very, very high-risk group of patients.
But I think people need to understand the biology. You know, the reason why that population was selected, it was not because they died in the first 5 years. It was because they had a recurrence in that first 5 years. The thing is, we have effective therapies. These patients benefited from CDK4/6 inhibitors in the metastatic setting, other targeted agents, novel. They went on a trial, so they may have gone on other trials, novel endocrine agents, ADCs, sequential chemotherapy. Even with high-risk disease, patients with hormone receptor positive disease tend to have longer durations of response to these therapies. So I think it's actually really encouraging for us that we're helping patients to live longer in the metastatic setting, but it doesn't negate the benefit. And I actually thought the timing was exactly what you would expect for this population of patients. And now that we can dose escalate from the TRADE study, which we already were doing, the abemaciclib, it makes it much easier to manage. And knowing that a lot of people took 100 milligrams BID and still got that benefit is very helpful.
No, absolutely. And then at the same symposium last year at ESMO, we also saw the trend in benefit for NATALEE in terms of the overall survival. Were you surprised that with such a broader group of patients that were intermediate risk, that at 5 years we were beginning to see that separation compared to monarch-E, where it took a lot longer? It took 7 years.
Well, monarch-E, there was a numeric difference, and at the last presentation, at 5 years, there was, even at 4 years, there were fewer patients living with metastatic disease, almost identical to what NATALEE has shown. So I don't feel like it's really all that different. I think it's exactly what we expect. You see those, these bar graphs, who are the number of patients living with metastatic disease who are going to die of their cancer. And we know that this is the case, that there are just fewer patients. And so, it takes a while to see the survival differences become statistically significant by very complicated statistics that we use. What is the right p-value that makes it statistically significant? And those are important data. So I don't think you can do the cross-trial comparisons here. I think they're both effective therapies. So.
Absolutely. So if you have a patient that's got 10 lymph nodes that's positive, and so it's overlapping both NATALEE and monarch-E, would you give both options to your patient and feel very comfortable that both are effective in that particular group of patients?
Yeah, I mean, a lot of people say they divide up because they want to use both drugs. So for the more NATALEE unique population, use ribo. For the more monarch-E focused population, use abema. And I think, what I talk to the patients about is the difference in toxicities and the duration of therapy. And then we decide together, tell which populations were included and how many were included. Monarch-E obviously had slightly more patients who had a higher risk disease than the NATALEE population. But I believe both drugs are really effective. And I will say that, one of the things that's a little encouraging with ribo is who wants to stop therapy for somebody with 10 positive nodes? So at least you're getting 3 years. So, I have one patient who had, lobular cancer, got neoadjuvant endocrine therapy and ovarian function suppression, and still had 8 positive nodes at the time of surgery. And she's now been on ribo for 5 years. I say really quietly because it's way outside, any data we have, but she just can't. She just doesn't feel comfortable stopping. It's a lobular cancer. We know the risks are enormously high, premenopausal woman. And, I tried to talk to her. We could check ctDNA, and if it was negative, maybe you could stop the ribo, because she now has vitiligo, which is a very rare but reported toxicity from long-term exposure. And she said, well, here's the problem. She thought about it for a while. She came back. She's very smart. She said, if it's negative, if I stop, it might become positive. And if it's positive, I'm going to be really depressed. So I'm not doing it. I mean, it's very smart.
Yeah.
So, but I think,
lady,
it's tough. And so she's really, it's almost like you're standing on the edge of a cliff waiting to fall off. So there is that appeal to 3 years of therapy. But, I think we just balance for the individual patients and use the different drugs. And, obviously there's liver enzyme elevations that cause discontinuation. About 9% of patients on NATALEE, and those patients you don't want to, not offer them a CDK4/6 inhibitor. And in fact, if they're modest elevations, sometimes you can restart and it recovers quickly. You can restart with ribo, or you can dose reduce, or you can switch to a BEMA. So there's a lot of options.
So if you look at NATALEE and you look at monarchE, although adding a CDK4/6 inhibitor, patients are doing so much better, there's still a lot more room for improvement because patients are still recurring. What do you think we need to do for those patients? Should we be increasing the duration of a CDK4/6? Should we be changing to an oral SERD plus a CDK4/6? Or is there something different that we need to be thinking about for the future?
Well, I think the something different part is the future.
Okay.
We're not quite there yet. I think, looking at ctDNA and seeing if we can potentially rescue patients before they develop visible metastatic disease. I will say the problem with that is that we don't see metastatic disease with ER-positive cancer well. And we've seen this in the metastatic setting, including quite recently with SERENA-6. The imaging doesn't pick up very endocrine-sensitive disease well. Mm-hmm. But I definitely believe that oral SERDs will be part of our treatment based on lidERA. I mean, it was just so surprising to see that data at an early follow-up. I mean, less than 3 years. They have a moderate and high-risk population. The difference is in the high-risk population, bigger in tamoxifen-treated patients in the control than AI, but the confidence intervals don't cross 1 even for the AI. And that's really remarkable, I think. And to me, we all see the data before the meeting, but seeing that data presented, I thought, wow, we're going to cure more women with this cancer. I think it's some amazing data and really exciting. It's sort of, for all of us who only do breast cancer, it's sort of a lifeline in a way, right? Now we have to tackle those triple negative patients who don't respond to therapy, but whose cancers don't respond. But this is, going to be remarkable. We're going to give it with CDK4/6 inhibitors. People said when that data came out, oh, well, maybe we don't have to use the CDK4/6 inhibitors. I'm like, really? Is your clinic not full of people with metastatic hormone receptor positive disease? I mean, my mother died of this disease, 1 centimeter node negative ER positive cancer. But, at the time when she had her diagnosis in the early 80s, those patients didn't even get endocrine therapy. And I think of where we've gone from then to now, unbelievable.
Unbelievable. My final question, because it's been so interesting, is what are we going to do as these patients begin to relapse while on CDK4/6 inhibitor? How are we going to tackle these patients in terms of their therapy?
I think, it's an interesting question, and we don't know because it's a small percentage of patients, even now, which I think is already telling. But the curves are still going down, of course. Most, I think, patients will relapse after their CDK4/6 inhibitor, not on. And I think that will bring up the question about whether or not we could somehow stratify patients to take longer therapy or use ctDNA to restart therapy. But the trials that have looked at that, which the DARE trial tried to look at, have had a lot of trouble recruiting patients because the ctDNA positivity is low in this patient population. But in the patients who've had a CDK4/6 inhibitor, I think we want to try putting them back on and seeing. We always use a year. We have no idea that a year is the right period of time. I think, if somebody doesn't have like massive systemic recurrence and they're still very ER positive, more than 6 months, I'd probably re-challenge with a different CDK4/6 inhibitor. We have the switching studies, a component, a subset of patients from EMBER-3, and then the post-MONARCH trial that suggests that these very endocrine-sensitive disease subsets, even with a little bit of visceral disease, would respond. So I would do that. I think switching to an oral SERD, I hope, will be an option even outside of the patients who have acquired ESR1 mutations. For patients who are recurring while still taking a CDK4/6 inhibitor, I think this is going to define a group of patients who are rapidly losing endocrine sensitivity. Obviously we're going to need to have biopsies in all of these patients to make sure they still have ER-positive disease, which a lot of them may not. We'll have to see as we track these patients in the real-world setting. But also, it's going to be a real question about what to use in the next line setting. I mean, we have data from Avera, Elevate, EMBER-3, suggesting that we can use oral SERDs in combination with targeted agents, and that we're going to see a benefit outside of patients who have ESR1 mutations
Absolutely.
alone. And I think that will be our next step in patients, probably even if we're sort of on the fence about the endocrine sensitivity. And then there's a group of patients who are going to recur who just have bad cancer, and we're going to go to chemo and ADCs. So we didn't really, Ascento 7 recently looked at SG in the first line setting, but we didn't have those patients who have true endocrine resistance. And in those patients, I think an ADC may be a best first step. Probably going to use TDXD mostly in that setting to try and improve survival, but we don't even have the survival yet data from Destiny Breast 06. So, but I think that's what we're going to do.
Well, thank you very much, Hope. I think today's conversation has been awesome. It's awesome for patients to know that they've got so many options that are now improving their prognostic outcome, both in the early stage setting and in the metastatic setting. So thank you for being here at the Asia Pacific Breast Cancer Summit in lovely Penang, and I hope you enjoy the rest of your stay.
Thank you so much for talking. It's a really exciting time.
Thank you.